You're listening to Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion on the topic of idiopathic pulmonary fibrosis, or IPF. I'm Dr. Jeff Swigris, and today we'll be discussing palliative and supportive care for individuals with IPF. With me today is the founder and director of the multidisciplinary collaborative interstitial lung disease clinic at the University of Alberta, an award-winning instructor who supervises students, residents, and fellows. Her multidisciplinary clinical team emphasizes collaboration and patient-centric teamwork. Her research focuses on assessments and treatments of dyspnea and other symptoms of interstitial lung disease, developing advanced care planning for patients and caregivers, and describing the impact of this care model on health outcomes and related economic analyses. Dr. Meena Kalluri, welcome and thank you for making time for this conversation.
Thank you, Dr. Swigris. It's truly a pleasure to be here with you.
So, as your introduction hinted, your clinic has been recognized both locally and nationally, really internationally, for its innovative approach to palliative and supportive care, end-of-life care for patients with advanced lung disease. The multidisciplinary team you direct has developed strategies to treat dyspnea, and you and I have had conversations about that. I'm really impressed with how carefully you thought about dyspnea, its measurement, and its treatment in these patients and how it affects their quality of life. Tell us how you decided to break ground in that area. What has drawn you to that aspect of pulmonary medicine?
I think, like many clinicians, I was influenced by what I saw in the first few years of starting practice. As soon as I'd completed my fellowship and started the ILD clinic here at the university, I began to become really interested in patient narratives. And I spent a lot of time exploring these narratives in clinic and allowing patients to talk to me about their symptoms and what it was doing to their routine life. So, for example, if the patients were breathless or were dealing with their cough spells, they would tell me how it was affecting their function, how it was affecting their work or their daily life at home. And I think that's what began to instill in me the profound impact that this condition was having on these patients. And it was not just the patients, it's the family that suffers with it. And when I began to process all of these things and began to reflect on how many of these things we actually address in our traditional clinic, the biomedical model, where the emphasis is on making a diagnosis and prescribing pharmacotherapeutic agents, it became very, very clear very, very quickly that that sort of an approach was very reductionistic towards patients. And in order to mitigate some of that and in order to address this huge spectrum of need, I figured out that I had to go out and retrain myself in some of these ways of assessing patients. So I found colleagues who were interested in rehab. I found colleagues that were interested in palliative medicine. I shadowed them. I left the comfort of my clinic and did lots and lots of home visits. I spent time with oxygen vendors. I spent time with physiotherapists, respiratory therapists, just to learn from their professional assessments what these patients were going through and what could be done to enhance assessment and care. So I took all of this knowledge, came back to clinic, developed pathways and protocols, had to train my own staff here at clinic, and then sort of create this network of individuals who would help me look after these patients in their community. So that's how it all started. What really hit home was this case of a 59-year-old veteran that I saw in clinic. He had familial IPF, was waiting on the transplant list. When we saw him in clinic, he had become a shell of a person of who he really was. He was very active, outgoing, volunteered for his community, avid golfer, camper, fisherman, who was now stuck indoors simply because he was breathless. His symptoms had not been managed. He was on high flow oxygen, didn't know really how to commute life and to deal with equipment and needs. So using this comprehensive multidisciplinary approach, we focused on symptoms. We had a systematic way that you alluded to of assessing breathlessness. We used oxygen. We connected with the vendors, made sure he had equipment, and used opiates in the right doses, small doses earlier on. And long story short, within 2 weeks of him being assessed in our clinic, he was able to not just negotiate his daily life at home, he was able to have a conversation, have a good night's rest, and most importantly to him, he was able to attend all 4 quarters of a hockey game. So while he didn't really make it to receive his transplant, in the time that was left between him and his family, he was able to achieve some meaning, some joy, some purpose. And I think that's what showed me that palliative care really has a transformative effect for the patients and for the families when it's done well. And even if the final outcome is a transplant or death, the way you live your final days, weeks, months can be very powerfully impacted when you use palliative care well.
So the way that I talk to patients is we want to keep you living as well as possible for as long as possible, whatever that means to the patient and their caregivers. As you alluded, it has such a profound impact, not only on the patient, but the whole household. So what do we say to patients with advanced lung disease, with IPF or other fibrosing ILDs, maybe who are early on? I'll sometimes say, let's think about palliative care. I think that scares patients, but what does it look like for them?
I think you're absolutely right when you talk about the fear that this word engenders in people, in the lay public, sometimes for the family members, because when they hear the words palliative care, they're really hearing that their clinician is no longer able to look after them, or everything, quote unquote, everything has been done. And now we need to have a change in philosophy of care. Perhaps they have to go and visit a different team, see a different professional. So I think it has a lot of different connotations, because from a patient perspective, what I've heard is that even though we're saying we want to do more and we want to be able to provide for your needs, and maybe I'm not the most qualified, so I will get another colleague to help me out. What the patient and sometimes the family essentially hears is that you, as the clinician who knows them best, you, the expert in ILD, are abandoning them. I think that's what they hear a lot of times when they hear us say, we'll probably be sending you over to see somebody else who's an expert in palliative care. I've also noticed that a lot of times the way we phrase palliative care sets up these myths and wrong ideas in patients' head. And I've been guilty of that. Plenty of times earlier on in my career, I've said things like, we've done everything we can and now there's nothing more to do, and therefore I'll send you to palliative care. So sometimes we're equating nothing more to do with palliative care. And if there's one thing I've learned after doing this sort of additive care in practice, is that it's so far removed from doing nothing more. It actually means doing more than just disease-focused care. It means taking care of the patient's symptoms. It means taking care of their oxygen needs, their supportive needs at home, managing their family, etc. One of the first things I do is to let the patients and the family know we're not abandoning them in any way. We're only wanting to do more for them and not less. And I think that sets them at ease right off the bat. I also tell them palliative care is quality of life medicine. So we're not just going to focus on antifibrotics or immune suppressing medication. We're actually going to start working solidly on what we can do to improve your quality of life. So I think that's another assuring thing for them to hear. The needs of a patient will differ depending on where they are in their disease trajectory. But what I've found is even when there's not a lot of physical symptoms, just the fact that you share with them that they have IPF now breeds in a lot of uncertainty. There's uncertainty about progression. There's uncertainty about how or when end of life may arrive, uncertainty about transplant, whether or not they'll get it. So it brings in a lot of anxiety for people because we're not very good dealing with uncertainty. So I think that requires a very sensitive, a very informed conversation where you allow the patient to process that information, you're allowing them to ask questions, and you're providing that time and space for this discussion to occur. So earlier on, even when they don't have a lot of physical needs, there is an immense need to address this information gap with the patient as well as their family. As the disease advances, you start to suffer the consequences of breathlessness or a cough spell, or you're fatigued. And then that means now your focus shifts and you start to talk about symptoms and how do you assess them? How do you use non-pharmacological strategies like behavior modification or activity modification? And what I've found is that this is sometimes the hardest thing to do because patients have lived their lives a certain way. When they go out for a walk, they walk in a certain way. Now you're asking them to change everything about themselves, how they do an activity, how they walk. So that takes a lot of work, and you have to work with physiotherapists, sometimes occupational therapists, sometimes family members in order to remind them how to pace well. Then there's the oxygen. I find that that's one of the most neglected aspects of pulmonary medicine. We need to start thinking about oxygen much like we think about any of our medications. It needs to be titrated. So just starting them on an oxygen prescription and leaving them on is not going to be sufficient. So paying attention to that. And then, of course, opiates are important, but they're not the be-all, end-all of dyspnea management. You need to use them at appropriate times, at appropriate doses. You need to empower the caregivers. You need to share an action plan with them. Just like we have action plans for COPD and asthma, I think about action plans for symptoms for my patients, provide them these action plans in writing so that they feel confident and empowered at home. And then the final piece is to find some sort of a community network, either a community nurse or a respiratory therapist that can accompany the patients to their homes and provide them this ongoing education. So I would say this is the span of the spectrum, and then end-of-life care is its own different modality where you're talking about other things like symptom crisis. You're talking about need for palliative sedation sometimes at home, need for providing respite to caregivers. So it's the same principles, but it's escalated to a completely different level. In a nutshell, palliative care to me is just that. You look at symptoms, you assess, you manage it, and then you try and help the patients and the family prepare for a future which is fraught with uncertainty.
I think that one of the things you alluded to in that wonderful summary that you just gave was our communication. So physician or practitioner's communication around palliative care. And I think we could do a better job managing expectations up front. And maybe it's just around the way that we talk to our patients. Things may change, but no matter how bad it gets, no matter what this condition looks like, we are going to be managing your symptoms or attempting to manage your symptoms so that we maintain your quality of life. And I think not necessarily predicting, because we can't really predict disease course with any certainty, although most fibrosis or certainly most cases of IPF progress. But I think saying something like, if this gets worse, our focus will continue to be on your symptoms and your quality of life, and how we manage those may change, but we're still going to be involved. Setting patients up for that early on seems like an appropriate thing to do. Another thing that you mentioned was getting patients to modify activities or change activities. And you and I both know that can be really challenging for these patients who really, as the disease progresses and they become more short of breath, maybe need oxygen and can't do the things that they once did. There really is a grieving process. They grieve that former life where they were much more carefree and active. And I think that, as you said, bringing in more folks who are talking the same message, that here's how we need to think about things now for you to get along in your daily life and accomplish the things that you want to do or that you need to do with fewer symptoms and better quality of life. I want to ask you a specific question. So actually a couple questions. I want to spend a little time on narcotics. So many patients and their caregivers have real concerns and trepidation over using narcotics. And as much as we say, I think this is going to really help you, can you share with us your approach to that? So how do you start talking to patients about using narcotics to manage dyspnea?
Sure. I think there's a lot of trepidation around narcotics, and understandably so, given the ravages of the opioid epidemic that we've all seen. So this is coming up in the clinical conversations more and more, especially in the last 4 or 5 years that I've observed. And to give you an example, just a few weeks ago, we had a patient who was recently discharged from the hospital for worsening of his IPF. He had hypoxemic respiratory failure, ended up being prescribed opiates, and was sent home. So he goes home, and because of his history of abuse, he actually didn't use it. So when we saw him in follow-up in clinic, he was very clear that he did not relish the idea of starting the opiates again after having struggled with the addiction and worked very, very hard to come away from it. So I think it's important to acknowledge that and to validate a patient's concerns. But then I always link it back to what the patient's goals are. What is the current situation? In this case, we went through this patient's detailed symptom inventory and we figured out that he was starting to have crisis. And I like the idea of not just measuring in terms of its disability, but to really talk about symptom intensity. So it became very clear through assessment that this patient's symptom intensity was fairly high. His intensity was almost 8, 9, 10 out of 10. When we asked him what his goals were, he basically said that at this point, given his advanced disease, he really wanted to be able to walk independently to the dining room, sit down, have a meal without being breathless or coughing too much, and having a conversation with friends. And using oxygen, pacing, all of the non-pharmacological strategies we had optimized, he was not able to do that. So I think the patient became very well aware of it because of the way we assess symptoms, and we pointed out how he was having crises. And that's when I start to have the conversation about opiates, because I am very clear with my patients about how we approach this. We always tell them that we're using the lowest possible doses. We're always using it in a very thoughtful, systematic fashion, only after optimizing everything else. So thinking of it as really as a last resort. When the patients have clarity and we're able to link how the current strategies are not effective in ameliorating the distress, I think they become more open because they're suffering through this crisis every day. And most patients want relief. So in this particular patient's case, we offered him a prescription. He was willing to purchase the drug. And then we also arranged a Zoom appointment. We had him take the first dose under observation. So unlike using opiates round the clock, sometimes when it's predominantly for treating exertional dyspnea, I like preemptive dosing, meaning take a small dose just before the activity so that it blunts that distress and you're able to perform without causing too much discomfort. So in this gentleman's case, we gave him a supervised dose. On Zoom, he takes the dose, is able to walk back and forth to his dining room, have a conversation. Distress was blunted and his numbers were about 4 out of 10 instead of being 8 or 9 out of 10. So clearly, he was able to accomplish his own goal. He was able to have a conversation and he saw that the control was in his hands and he didn't suffer any consequences from it. He became empowered through that experience. So I think it takes time, a personalized approach, and to be very open about communication and when you're going to use it and how you're going to use it. Shared decision-making is the key. Once you provide them that education, I feel like that's the most empowering part of self-management because it is in their own hands and they understand when to use it and how to use it.
And you mentioned low doses. Talk to us about your dosing strategy for the pre-exertion or pre-exercise, pre-activity dosing, as well as rescue dosing. How do you approach that?
So I think most of the literature, if you were to quickly scan through the RCTs, which have been focused on advanced lung disease, COPD-related trials, they tend to use doses upwards of 5 or 10 milligrams, extended release sometimes, using them twice a day. I know of an IPF study which used about 5 milligrams 4 times a day. In my own personal experience, I found that that's a fairly high dose to use. And if you start to think about preemptive dosing and pre-exertional dosing, you really don't need that kind of high dosing, and you certainly don't need to give this round the clock. And that right off the bat shaves the amount of opiate that you're using, therefore reduces side effects and the potential of abuse and the potential of overdose that sometimes worries patients a lot. So when I say low dose, I'm talking about starting off with something like 0.5 milligrams of morphine or 0.1 or 0.2 milligrams of hydromorphone. And that's the dose we start off at, especially when the patients are frail, they're elderly, they're opioid naive. So that's how we start. And then we use the dyspnea NRS to really titrate and to understand when to increase the dosing, etc. It's also guided by the number of crisis episodes they might have, also optimal use of oxygen and optimal use of all other strategies. And I find that that really is the sweet spot where you've optimized everything else and you recognize very clearly that the symptom intensity is still there in spite of optimization. And that's the point where we introduce opiates and titrate it very, very carefully, very, very systematically. The other piece that's really important is to not just prescribe a dose and say follow up in a month, 2 months, 3 months, but to have a case management approach where either the nurse from your own clinic or nurses in the community where there's an ongoing follow-up. So typically when we start opiates, we're following with these patients within 2 or 3 days via Zoom or via telephone calls rather than waiting for an in-person or clinic follow-up that happens in weeks. Close follow-up is the key.
Ed, you mentioned NRS, nominal rating scale. So you shoot for a certain number, like we want your dyspnea cut in half or below a 3. Is there something you shoot for, or is that just individualized?
I think a combination of both. We tend to use the cutoffs that are available in the literature from pain and dyspnea. Generally, anything above 7 is considered quite severe. 4 to 7 is considered moderate. So I'm aiming for something below a 4. But then these are also very subjective things. So in certain situations, I would ask the patient if this is enough relief. Are they finding significant relief? Because the ultimate goal is to make sure that the patient is feeling the benefit, the patient's seeing an improvement and can at least function at a reasonable level without being distressed.
I feel like we could talk for another 2 hours, but we're running low on time. So given all that we've covered in this short time, the average practitioner who's treating patients with fibrosing interstitial lung disease, idiopathic pulmonary fibrosis, and others, what should we all be considering differently in terms of our approach to symptom management, palliative care, or quality of life care? What would you emphasize for those of us taking care of these folks?
One of the most important things is to recognize that palliative care is now being thought of as active holistic care. I know all clinicians pride themselves in delivering patient-centered care. We all want to do the best that we can for our patients. The recognition and understanding that palliative care is really a natural extension of routine clinical care. To fully imbibe that, to fully accept that, so that we as practitioners, as providers can now go forward and say, yes, this is my job. This is part of what I do. This is something that I will deliver. It's my ethical and moral responsibility towards our patients because our patients deserve it. That's the new reality. So the next step is really to reflect on your own practice and see, where are my gaps? What can I improve? And there's no harm or no shame in admitting that there are some things that we don't know, and feeling free to acknowledge that and reach out for help, whether it's some sort of an informal training or formal training, so that we all build competency. Because it's like anything else in medicine, like doing an ABG, putting in a chest tube, or doing a central line, it takes practice. So whether it's to become comfortable understanding how to prescribe opiates, how to titrate it, or to have a sensitive, informed, well-meaning, advanced care planning conversation, it's a skill, just like any other skill in medicine. Low-hanging fruit, I would say, is start to incorporate some sort of a NRS scale for measuring symptom intensity. It's relatively quick. It doesn't take more than a minute or so if you have 3 or 4 symptoms to do. And once you recognize that, you'll begin to appreciate the burden that these patients face. And I have no doubt that clinicians, when they're faced with that reality and they know that it's their responsibility, it's part of their job, will rise up to that occasion. I have no doubt at all.
Very well said. Very well said. Meena, thank you so much for being here today and for sharing your expertise. It's been absolutely wonderful. Thank you so much.
Thank you so much. It's been a pleasure chatting with you.
And to the audience, thank you for listening to this conversation on idiopathic pulmonary fibrosis with our guest, Meena Kalluri. There's much more ahead in the upcoming episodes, so be sure to check out the Medscape app and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.